Hello and welcome to Healthline. My name is Alex Kolignamos and I'll be your host on today's program. So glad to be filling in for my friend Gregory Zarian. Today's topic is breast cancer preventative care and treatment, as October is Breast Cancer Awareness Month. Did you know that 1 in 8 women will be diagnosed with breast cancer in their lifetime? Breast cancer is the most commonly diagnosed cancer in women. Each year it is estimated that over 246,660 women in the United States will be diagnosed with breast cancer. Of those, more than 40,000 will die. On average, every 2 minutes, a woman is diagnosed with breast cancer, and 1 woman will die of breast cancer every 13 minutes. That means that since you've been watching this show, 4 women will have been diagnosed, and 2 women will die by the time this program is over. But there is hope. Over 2.8 million breast cancer survivors are alive and well in the United States today. Being that it's Breast Cancer Awareness Month, it's a fitting time to ask questions, address concerns, clear up misconceptions about breast cancer, and who better to do that with than our friends and esteemed doctors from Glendale Adventist Medical Center. Welcome to our Healthline doctors, guests Dr. Boris Bagdasarian and Dr. Serineh Melidonian.
I'm Dr. Boris Bagdasarian. I'm a native of Southern California. I was born and raised in Montebello. I went to an Armenian school called Armenian Mesrobian. I did my formative medical school training at Western University of Health Sciences. My training in internal medicine was at White Memorial Medical Center, and my formal training in hematology oncology over at the City of Hope National Medical Center, and also affiliated with Harbor UCLA. I've been practicing in Glendale since 1999. I'm currently the managing partner of the Los Angeles Cancer Network, which now spans throughout greater Los Angeles in 9 different offices from Montebello all the way through San Fernando Valley. But my main niche is here in Glendale, and I've been chairman of the cancer committee at the Glendale Adventist for close to a decade now, and I'm proud of all the achievements that the Cancer Center has made. It's been recipient of the Outstanding Achievement Award, which was a rare award given only to the very best cancer programs in the country.
Doctor?
And I'm Serineh Melidonian. I was raised in Los Angeles. I'm also a graduate of the University of Southern California. I went on to Tufts for medical school in Boston, and then returned to USC to complete my residency at LA County USC Medical Center. And since 2007, I've been practicing at Glendale Adventist Medical Center in the emergency department. My focus is a little different in that I see emergencies, but I see everything in the emergency room, from a sprained ankle. In this case, I'll see tender breasts, breast masses, all the way to heart attacks, strokes, and any kind of belly pain you can imagine.
Well, as you can see, Glendale Adventist has excellent doctors. Did you know that Glendale Adventist Medical Center is ranked 4 out of 5 stars by the Centers of Medicare and Medicaid Services for its star ratings? That's top 20% in California. And for its comprehensive stroke center accreditation from DNV-GL Healthcare USA. You can always call the physician referral line at Glendale Adventist Medical Center for personalized physician referral to find a doctor that is right for you. You can call 818-409-8100 for help today. You can also visit us online on social media, Facebook, Twitter, YouTube for watching videos, and LinkedIn to get health tips and to learn more about Glendale Adventist Medical Center. Stay tuned, don't go away. Questions for our doctors when we return after this break. Welcome back to our program. And now some questions for our guest doctors, Dr. Bagdasarian and Dr. Melidonian. Doctors, what are the signs of breast cancer?
Typically, a woman initially is found to demonstrate a palpable lump. These are the physical signs that most women will appreciate, and that lump may be either in the breast or in the axilla, which is the armpit area. At times, women may claim that they've had a mammogram, but mammograms are not 100%. You know, in the old days, the mammograms had a 50% false negative, and you know, currently the newer digital mammograms are far better, higher definition. However, there's still a 5% chance that something might be missed. So if a woman were to appreciate a palpable nodule, that needs to be immediately addressed to the physician, and 90+% of these need to be biopsied if they're, you know, suspicious in that chronologic sequence. Now, other signs are dimpling. If a lesion is quite deep within the breast and a woman has large breasts, this can be appreciated when the arm is lifted above the shoulders, or if the hands are placed on the hips, and you can see this dimpling effect. If this is appreciated, then it's extremely important for a woman to seek medical attention. Or if there's redness on the surface of the skin, swelling or tenderness, that may not be a sign of malignancy, or it may be infection, but it's very important for a woman to seek medical attention immediately.
Doctor?
Additionally, if you see discharge, if there's any kind of discharge, blood or clear from the breast, especially if it's only on one side, that's very abnormal, and they should seek care for that.
So then take us through the steps. What does someone do once they discover they have a lump?
First things to seek medical attention with their primary care physician. A well-rounded physician will immediately refer the patient to have an ultrasound guided biopsy. Or a stereotactic biopsy. That's one of the first key things that is necessary, along with mammography, obviously. Those are the combination. So, you know, some doctors feel that let's go ahead and do the mammography initially, but if there's something that is suspicious, it needs to be done together. All of these can be done under one setting if authorization is submitted for their insurance, or if they have private insurance, there shouldn't be an issue where everything could be done within 1 day.
I think the most important thing is to stay consistent. So after you've had your first mammogram, staying with the same facility so they can compare the two. And the difficult thing is people will come to the emergency room hoping to get an answer. They felt the lump, they run to the emergency room. But really it's something that has to be done through the primary care physician's office and through the same, ideally the same breast center or the same mammography center, so they can compare the old film to the new film and see if there are even some slight subtle changes in the microcalcifications. And those are signs of breast cancer on the imaging. And it's very difficult one time looking at it, assuming maybe this is just dense tissue. You really have to compare it to an old film. And so when you do it at a center of excellence, the way Glendale Adventist has at the breast imaging center, they're able to compare with the outside films and get outside records and compare the images and look for those subtle changes.
Well, tell me, what is a mammogram and how should one actually go about getting a mammogram? How often?
Mammograms are radiographic imaging studies that is of low radiation intensity compared to the older films, especially the digital films that we have now. The quality of the film is far better and the definition much improved. Mammograms, according to the American College of Physicians, they're recommending for women with minimal risk, meaning no family history of breast cancer, to undergo imaging starting at age 50. However, the American Cancer Society and the Commission on Cancer recommends mammograms to be performed starting at age 40. The data that was looked at, that was presented, was a historic data spanning over 40-something years. We've unfortunately seen a marked increase in the number of younger women with breast cancer over the past 20 to 25 years. Hence, it's, according to the American Cancer Society, it's 40 and above, and the doctor's discretion. It was revamped, or the guidelines changed to also include, women in their early 40s based on the American College of Physicians, which is the main standard governing body. So, however, if there's a strong family history of breast cancer with one or more first-degree relatives, we recommend mammograms to be performed 5 years before that individual's or family member's diagnosed age. For instance, if a mom was diagnosed at age 40, the daughter needs to be imaged at age 35.
I see. I see. Why is there so much breast cancer in the world today? Why are women getting it at age 40? What are some of the causes?
Good question, Alex. It's the same question we're asking, why are we seeing such a large increase in other malignancies? And there have been many articles published in the past decade looking at environmental factors. We know that diet has a lot to do with development of certain malignancies. One of my mentors at UCLA, Dr. Chabowski, was well known for his work on diet and risk of developing cancer. 5,000 women were studied for 10 years who were obese or had a poor diet. The other half were slender or had a great diet. There was a 15% increase in developing cancer in the overweight or poor diet group. So diet alone is also a known factor.
It's critical.
And
Absolutely.
the environment, unfortunately we're exposed to so much in terms of the chemicals in the food we eat, the water we drink, and the air we breathe. And especially in the metropolitan areas. And you can clearly see a higher incidence in metropolitan areas compared to other parts of the world, or the United States rather, especially rural areas. So clearly the pollution and carcinogen exposure has been implicated.
Well, with that, doctors, let us take a short break. We'll be back after this break answering more questions with our doctors. Stay tuned. Welcome back to Healthline. My name is Alex Kalagnamos, and we're joined today by our guest doctors, Dr. Bagdasarian and Dr. Serineh Melidonian. Our viewers are wondering, what are the different types of breast cancer?
There are non-invasive and invasive types of breast cancers. Non-invasive is generally identified on mammogram. So, for instance, typical findings would be calcifications, trabeculations, and at the time of biopsy, they can identify malignant cells that have not penetrated through the basement membrane into the adipose tissue, and so hence it's a non-invasive component. Those are 95+% cure rates and addressed surgically with radiation typically.
And again, what stage would that be?
That would be a stage 0.
Stage 0.
So other malignancies, stage 1 and above, are ductal carcinomas, for example. So 80% of breast cancers are ductal, meaning that the disease is within the ducts. So we have milk glands, malignancies of which are referred to as lobular. 20% are lobular carcinomas.
Okay.
And the ducts that run from the gland to the nipple, 80% of the disease is identified within the ducts. And as it penetrates into the adipose tissue, it's regarded as invasive disease. So it could be anywhere from stage 1, 2, 3, or if it's spread, stage 4. So the key prognostic indicators are lymph node status. So at the time of diagnosis, evaluation of the axillary lymph nodes, the lymph nodes within the armpit, are extremely important. So the higher the number of lymph nodes involved, higher the probability of distant spread and risk of dying of this disease. Then comes the size of the tumor. Mm-hmm. So generally, thank goodness for mammography, the stage of disease is typically within stage 1 or 2 in the majority of women, and it's rare for it to be identified in much higher stages, especially if they are religious and going in for evaluation. Now, lobular carcinoma sometimes can have multiple areas involved, and hence this is really important to obtain an MRI, which is a different imaging modality, And for women who are premenopausal and have dense breasts, because tumors can be obscured by these dense glands, and hence the MR is a much better modality. Some may ask, why not just do an MRI all the time? Well, MR will not pick up those minute calcifications that the mammogram does.
I see.
To pick up early stage disease. So the two are very important, especially in our younger women, to evaluate.
Now, we are so focused on talking breast cancer about women, but men should be concerned too. Is that correct?
Cancer does happen in men. Men can carry the gene, the BRCA gene, and unfortunately those stages, those men don't typically have mammograms. They don't know that they are at risk, and so we'll see them much more often later in the course of the disease, and they may come to the emergency room for unexplained rash on their breast tissue, and it's only after the diagnosis is made that they find out that they even carried the gene that put them at risk in the first place.
Wow. So really know your family history.
Knowing the family history is very important. Breast and ovarian cancer, BRCA 1 and 2 are the genes to be tested.
Absolutely, and we've had many of our women who've been diagnosed with the BRCA mutation have their family members, brothers, sons, for instance, evaluated, and because men are not only who are carriers of that gene not only have a risk of breast cancer, they have an increased risk in developing prostate cancer compared to the general population with the BRCA mutation, as well as pancreatic cancers and melanoma. So it's very important that many of these patients that have this gene be closely monitored and counseled and be sent to the appropriate genetic counselor for these important discussions.
I know so much of this sounds so alarming, but again, know your family history, do the self-examinations, regular checkups. All of that makes such a difference, doesn't it?
Have an open dialogue with your family, and try to get the history as much as you can from each of the family members, and look at the distant family too, because they may know more. Your parents may not remember, but your aunts and uncles may be able to fill you in on what grandparents had. And then have a close relationship with your physician to explain these are the things that have been happening in my family, and ask to have the regular mammograms, ask to have the extra testing if anything is concerning.
Thank you, doctors. More with our doctors, Dr. Bagdasarian and Dr. Melidonian, after this short break. Welcome back to Healthline. I'm today's host, Alex Kalagnamos, and today's topic is breast cancer. Did you know that GAMC received its third consecutive A rating hospital safety score from the patient safety organization, the Leapfrog Group? And Glendale Adventist is a high-performing hospital for heart failure by U.S. News and World Report. Do you want to learn more about the services offered by Glendale Adventist Medical Center? Visit our website, adventisthealth.org/Glendale. Today we've been discussing breast cancer with our guests, Dr. Melidonian and Dr. Bagdasarian. Doctors, some more questions for you. What types of treatment are there for breast cancer?
The number one modality of managing breast cancer is surgery. So after surgery, for which whether a female decides to have a lumpectomy, which is removal of the actual mass itself, sparing the breast, or having the whole breast removed, in addition to the lymph node sampling, we take a look at the pathology report to determine whether a patient requires chemotherapy. Typically, if the lymph nodes are involved and a patient is healthy enough to undergo chemotherapy, we would recommend that intervention. And the type of chemotherapeutic agents that we're utilizing and the supportive drugs, we've come a very long way in terms of anti-nausea, anti-fatigue measures, prophylactic growth factors to reduce the risk of infections, hydrations, etc. We really have kept patients out of the hospital, and the toxicities have really been reduced. and of course incorporating physical activity, nutrition. It's a multifaceted approach in managing our patients. And the other key question is, well, not everybody will require chemotherapy. There are patients who have perhaps a tumor that's a little large, however, the lymph nodes being negative. Does that individual need chemotherapy? For most who have what we call triple negative breast cancer, which means all three important receptors for the audience, we evaluate three key things: the estrogen, progesterone, and a protein called HER2/neu. The higher the expression of the estrogen and progesterone, the better the outcomes. The HER2 is also very important if it's highly expressed. It's extremely important to consider utilizing a medication called Herceptin and another drug, perhaps Perjeta, which neutralizes this protein because it downstream leads to a rapid cell division and proliferation. So there are ways to counter that. But going back to the question, does every female need chemotherapy? We have now wonderful testing where we do genetic profiling assays on the tumor. There are many different types out there, oncotype, mammoprint, where they look at anywhere from 21 to 80 plus genes to determine the risk of the disease relapse. And these genetic studies have been validated and studied on tissue dating back 20, 25 years on samples from the NSABP. So clearly you can see a very solid profile that is validated, so anywhere from low risk to high risk. So if a female has a low risk probability of recurrence, administering chemotherapy may actually be toxic and harmful for that individual, and it gives a negative score. Versus a high-risk individual where the benefit of the chemotherapy may be up to 20-25%, if not greater. So in the past, for many of our young women that did not have any lymph nodes involved, we would shotgun approach and administer chemotherapy as an insurance blanket and means of protecting our patients. But now with these wonderful tests, we can reduce the need for chemotherapy. And so we've come a long way in that aspect. And gene profiling is also playing a very important role in advanced disease as well, in carving out a clinical pathway of treatment for our patients with novel agents.
This is why Glendale Adventist is so amazing. We all know someone who's had cancer. I was in the room when my grandmother was diagnosed with cancer, and it's terrifying. And it does feel like a death sentence, but it's really not, especially with early detection and with all of this work that you're doing.
I think that's the biggest take home, that if you feel a lump, if you feel something, make sure you go out and get tested. Don't assume that you're getting a death sentence. Don't assume you're going to die.
It doesn't have to be.
It doesn't have to be. It doesn't. You don't know that it's cancer until you have tissue. Once you do have a biopsy and you have the tissue and you have the testing and you get the diagnosis, there are amazing experts like Dr. Bagdasarian that are able to cater to your needs, to that specific type of cancer that you're dealing with, and give you treatments. I can say, when I started almost 10 years ago at Glendale Adventist, you would see people that were having a tougher time dealing with a chemotherapy. Even that has gotten less over these 9, almost 10 years.
Absolutely.
Because the treatment modalities are changing and the approach is changing, and you have experts in the community that can help you.
Well, I know we touched upon this a little bit. In everything that you've seen, doctors, can you identify what are the contributing factors to breast cancer? Environmental? Is it the toxic environment that we live in? What is it?
Yeah, I think there are many factors. The number of children you've had in your lifetime, the duration of how long you've breastfed your children, if you've ever breastfed your children.
That's really surprising.
The
that.
relative risks are, ranging anywhere from 1.5 to 2. I think the key is family history.
I see.
So one of the key things is family history, and if there's a strong family history, we touched upon, Dr. Melidonian, mentioned the BRCA gene. I think those patients need to be screened for the BRCA mutation. That's extremely important. Smoking is a risk factor, not only for lung cancer, but for breast cancer, cervical cancer, etc. Obesity, being sedentary. These are important factors. Diet. But the environment lately has been the main thing, and focus on many things that the scientists are now looking at. Sadly, not only for breast cancer, for many malignancies. So we are doing our best to eat the right foods, to avoid smoking, to exercise, and stress is also a very important thing that's very rarely discussed, and it's found in almost every medical journal, whether it's heart disease, lung disease, diabetes. That's another means of reducing the risk. And
stress, smoking, but things like sleeping can really help, right?
Absolutely.
Rest,
Yep.
meditation, the right diet. Do you see this type of cancers in patients who are living, if you can say this correctly, by really monitoring their diets, getting the right amount of exercise, not smoking, not doing drugs? Can you actually see a difference in patients like that?
You definitely see a difference in the presence, but it's not. You can't protect yourself just by living the healthy life. Yes, those are. If you smoke, your chance of cancer is higher. But if you don't smoke, that doesn't mean you're safe forever. And having the right diet, you have to live the right life and hope that you don't have gene mutations or changes that will put you at higher risk.
Well, more with our doctors after we return from this short commercial break. Welcome back to Healthline. The topic of today's conversation is breast cancer. Doctors, one final question. What steps can be taken to prevent breast cancer?
I think the number one thing is seeing your doctor on an annual basis, to have your mammograms done on an annual basis, physical examinations, diet, exercise, alcohol in moderation, getting enough sleep, limiting the stress in your life, healthy eating habits.
And know your body. Really have to know your body and know what doesn't feel right, doesn't seem right.
Cancer Services at Glendale Adventist Medical Center is the only cancer program in Glendale to be accredited by the American College of Surgeons Commission on Cancer as a community hospital comprehensive cancer program. As part of these exceptional standards, communication among surgeons, medical and radiation oncologists, diagnostic radiologists, pathologists, and other cancer specialists is strongly encouraged, resulting in improved patient care designed to serve you, not only in your time of need, but also as you take the preventative steps discussed here today by our doctors. Doctors, once again, thank you so much for joining us, Dr. Bagdasarian, Dr.
Thank you.
Melidonian. Thank you. My name is Alex Colignamos, signing off for another episode of Healthline.